Afternoon, everybody. I am Dr. KAPADIA. I am a nuclear medicine physician. It is a privilege for me as a nuclear medicine physician to stand in a forum of esteemed surgeons and clinicians who are at the forefront of cancer care. And as a physician, nuclear medicine physician, I often encounter the continuum of a care which starts from your operating tables and it continues till the molecular domains of radioiodine therapy, where we used to refine and complement the treatment strategies. Now, my talk is in light of ATA new guidelines of 2025. So, our DATA framework has been given. So, we will move in this light only. So, my job started when the patient is referred to me. That is a post-thyroidectomy patient from oncosurgeons, ENT surgeons, and which is a differentiated papillary carcinoma of follicular or DTs. Now, 2025 ATA is classified this thing into three categories. First is papillary, then follicular, and another one is oncocytic. Oncocytic is now a separate group altogether. So, what is my role is to decide which patients needs RAI altogether, and if yes, how much less dose can be affordable. The dictum is less is more. So we have to review various aspects: histopathology, TNM staging, ATA risk categories, and then we move forward. So if yes, we have to see following things. First is TSH stimulation. Patient is off altroxin and we let the TSH to rise. It should be more than 30 milli-international unit per liter. Second thing is low iodine diet, which usually most of the referring surgeons, they just don't bother. It should be at least 2 weeks of low iodine diet. Iodine burden of the patient should be as low as possible, so that our thyroid become hungry, and whatever RAI is been given, it has been taken avidly. Thirdly is baseline evaluation has to be run, including serum TG as well as anti-TG antibodies, USG neck, and diagnostic whole body scan, which is known as pre-therapy scan. Now, as I mentioned, the foods which has to be avoided, which are high iodine sources of, include first and foremost is iodized salt. It should not be given. Patient should be instructed that no outside food should be given in this pre-iodine therapy period, which contains iodized salt. Senda namak, which can be used. Okay? No packaged food, chips, biscuits, breads, etc., which contains iodized salt should be completely restricted. Dairy products also contain iodine, that is stable iodine. Milk, curd, cheese, butter, paneer, ice cream, etc. should be avoided. Seafood and sea products are a good source of iodine. Egg white is okay, but egg yolk is to be avoided. Certain bakery items which contains as conditioner in iodate form, it has to be avoided. Chocolate, soya products, medicines including multivitamins, cough syrups, contrast agent has to be avoided at least 6 weeks prior to therapy. Now, RAI indications and iodine 131 administration. It has been broadly classified on the basis of intent. Intent could be ablation, adjuvant therapy, and therapeutic treatment. Ablation is a form which is used to destroy even residual thyroid normal tissue also. Dose is less, around 30 millicurie. Adjuvant therapy is for suspected intermediate high risk cases, to reduce recurrence, so that the dose is now on a higher side, that is 30 to 100 MCI. Therapeutic is a known metastatic disease or known residual disease, so it is the highest dose. It goes from 100 to 200 MCI, even 200 MCI plus can be given as and when required. Iodine 131 is given in a form of oral capsule or liquid. Next step is post-therapy scan and immediate care. Now, post-therapy scan has been given utmost importance even in ATA 2025 guidelines also. It has to be undergone 3 to 7 days after therapy. It is more sensitive, and it can also find few of those foci which can be missed in pre-therapy scan. At the time of therapy, a few things has to be taken care, like hydration. Sour candies are given just to protect the salivary glands. Salivary glands also contain sodium hydrate sympathus. In place of thyroid, the radioiodine can move into salivary gland, also causes salinitis. So these are few side effects, not complication. Nausea and salinitis very oftenly can be seen, and bone marrow suppression is a long-term thing. Now, the dynamic risk stratification has been very much emphasized on this in this 2025 guidelines. It says that risk stratification has to be done at every steps, even after therapy also, in follow-up cases. So we have to describe responses, which can be excellent response, biochemical incomplete response, structural incomplete, or indeterminate response. So risk category can be upgraded or downgraded at any time of the management. Now, a simple chart has been made here describing various categories and in respective dose which has to be given. Low risk category, now they are discouraging any radioiodine nowadays. If given, it has to be less than 30 MCI. Small tumors, no metastasis. All the categories of low risk, including unifocal tumor, lymph node, are generally absent, or if they are less than 2 mm, there should be no aggressive histology, no metastasis, no extra thyroid extension. So these tumors are low risk, and as such can be managed even without iodine, also on active surveillance and proper follow-up. Intermediate risk are generally taken for 30 to 100 MCI, high risk 100 to 150 MCI, and metastatic may get 200 MCI plus. So the trick is 0 to 30, 30 to 100, 150, and then 200. The next step is follow-up. Recurrence is the mainstay of follow-up is thyroglobulin, either suppressed or stimulated with anti-TG antibodies. Thyroglobulin interpretation should always be done in the light of context, and also trend is more important than an isolated TG finding. NEC USG, FDG PHCT if done when the tumor become iodine negative, and then lifelong TSS suppression with levothyroxine. Persistent and recurrent disease, if iodine avid, then we have to repeat radioiodine, and if not, then we have to think of some other modalities, that is surgery, EBRT, and TKIs. Now something about iodine 131. What is this iodine 131 is? There are plenty of isotopes of iodine ranging from atomic mass 108 to 114. 127 is the only stable isotope which we consume daily. That is iodine 127 is the So the stable isotope is iodine 127. And the biggest property of iodine 131 is that it contains both beta and gamma, both suitable for imaging as well as for ablation. It has got beta radiation. Beta radiation have DNA breaks and can be used for cell killings. Gamma rays enables scintigraphy and whole body scanning. Half-life of iodine 131 is 8 days. So that is why a period of 30 days is recommended for for irradiation precaution, because it is a good half-life of 8 days. Range is around 2 mm of beta, and it causes DNA damage and cell death. It is generated from nuclear reactor, tellurium targeted use. Gamma irradiation, it is for imaging. Why iodine 131 targets the radiation, the thyroid? Thyroid contains sodium iodide sympathos as receptors, which transfer iodine, any form of iodine. All the isotopes of iodine can be transferred inside with this sympathos. It gets selectively concentrated in thyroid tissue, delivering targeted radiation that destroys those cells while sparing surrounding tissue. So that's why it is a form of targeted therapy. Meanwhile, it is actually the first form of targeted therapy which was used 50 years before. Now in this era of precision oncology, I think it is the first kind of targeted medicine which is been evolved. As I said, double-stranded breaks and lead to cell death, apoptosis, and particularly effective in differentiated thyroid cancer cells. Can be used in papillary carcinoma as well as in follicular carcinoma. It is not useful in medullary and anaplastic thyroid cancer because these subtypes, they doesn't have sufficient amount of sodium iodide sympathos. Few important steps which we have to keep in mind after radioiodine therapy. That is, it has a physiological uptake in various tissues including thyroid, salivary gland, gastric mucosa, lactating breast. And route of spread is urine, it is a major source, and other sources are saliva, sweat, feces, lactating milk. And precautions is it has to keep distance. Distance has to be maintained only for gamma. Actually, beta has a range only of 2 mm, but it has a gamma radiation also. So we have to maintain a distance of 1 to 2 meters at least, so that gamma radiations can be avoided. So thus we need few practical radiation safety instruction post therapy. That is, distance has to be maintained at least 1 to 2 meters from each other. Limit close time has to be, the concept is as much as distance, as low as time, low time of contact, and shielding if possible. Hygiene has to be maintained. Flush toilet twice, wash hands thoroughly, no contact whatsoever, and particularly no contact with pregnant women and children. Now we come first is role in remnant ablation. Given after thyroidectomy to destroy any leftover oval thyroid tissue that remains post-surgery. Even normal thyroid tissue has to be removed, has to be ablated, so that in future thyroglobulin follow-up testing can be done reliably. And second is adjuvant therapy. Administered where there is no visible tumor but the patient has high or intermediate risk of microscopic residual disease. So goal is to kill occult residual cancer cells that surgery may have missed. Indication high/intermediate risk patient with no macroscopic disease on imaging. Treatment of unknown disease, treatment of known disease, that is metastatic disease, including lymph node, lung metastasis, and bone mets. Specifically, it is used when disease is iodine avid, and it can be repeated as number of time. As I said earlier, post-therapy scan, which is performed 3 to 7 days after therapy, is more sensitive than diagnostic scan performed before. Detection targets identify residual thyroid tissues, lymph node involvement, and distant metastasis. Where iodine 131 is not useful in RAI refractory disease, which has become de-differentiated. So in that cases, we have to switch on to tyrosine kinase inhibitor, that is next line of treatment. This has already been covered. Now, As per the new guidelines given, low risk ATA is generally mostly there are generally no requirement of RAI. It is limited only for intermediate and high risk disease, and it is recommended for intermediate, and it is mandatory for high risk patients. These are the kind of surgeries. RAI is typically administered 4 to 6 weeks post-op after wound healing is confirmed. Few of the complications of RAI include sialadenitis, that is salivary gland inflammation, and neck pain, thyroid bed inflammation. Lead complication include xerostomia. Secondary malignancy rates are high, are there, but it is rare. Fertility issues if high cumulative dose is given. Now, in RAI refractory disease, no iodine uptake or disease progression despite RAI, surgery becomes important again for resectable or symptomatic occurrence, and TKI therapy is the primary, is the systemic option. Surgery is preferred over RA in structural nodal recurrence, large lymph nodes, that is more than 1 to 1.5 centimeters, and non-iodine avid tissue disease. Golden rule is, if you can cut it, don't bund it. Common surgical pitfalls. Lobectomy before RAI leaves thyroid tissue that competes for iodine uptake, making RAI ineffective and TG unreliable. RAI needs an empty thyroid bed. So there is no role of RAI in post-lobectomy patients. Contrast CT should be avoided, as I said. Before iodine therapy, it should not be done before 6 to 12 weeks. So recent contrast, if it is given, RAI has to be postponed. RAI cannot compensate for residual bulky disease. So RAI treats cells, not masses. So if there is residual bulky nodes, it has to be reoperated. Similarly, TG must be interpreted in context of surgery types, RAS status, TSH level, and anti-TG antibody. TG is meaningful only when you know the background. Likewise, if the anti-TG antibodies are high, then low TG is of no use. It becomes unreliable. So then the mainstay of management will then become anti-TG antibody itself. So as my previous speakers has highlighted, there are few changes which are made in this new 2025 guidelines. Now the RAI has become more individualized, dynamic, and personalized care has been emphasized. Data framework has been used, including diagnosis, assessment of the risk benefit, treatment decision, and assessment of the response. Scope is narrowed to DTC only. Earlier it was nodules also, thyroid nodule also covered in it. So few of these things have been changed. First of all, risk category has been now 4-tier, including low, intermediate, high, and high risk. Low risk contain 10% risk of recurrence. Low intermediate is 10 to 15. Intermediate high is 16 to 30%, and high risk is more than 30%. Multifocalities has been stratified, whether it is unilateral or bilateral multifocal. Vascular invasion has already been described. If more than 4 foci in follicular FTC, then it comes into high risk category. Margin status also has been described, whether it is anterior or posterior. Posterior margin are more riskier than anterior. FTC and oncocytic separated. So as I already said, dynamic risk model has been given in this 2025 guidelines. Initial risk stratified, response assessment, and risk re-stratified at every steps.